Good afternoon and welcome to the Assembly Committee on Health and Human Services. Would the Secretary please take the roll?
Assemblywoman Gonzalez. Here. Assemblywoman Gorlow. Here. Assemblyman Gray. Here. Assemblyman Hafen. Here. Assemblyman Hibbets. Here. Assemblyman Koenig. Here. Assemblywoman Newby. Here. Assemblyman Nguyen. Here. Assemblyman Orentlicher. Here. Assemblywoman Taylor. Present. Assemblywoman Thomas. Chair Peters.
I am here. That is everybody here this afternoon. Thank you all for being here. Right. Bye. Just kidding. Don't leave. Couple housekeeping items and just reminders. I caught myself doing this yesterday. I didn't turn off my computer sound in the middle of committee. It ba-dinged on me. So please turn off your electronic devices so we're not interrupting speakers and our colleagues. Members of the public may provide testimony in a variety of ways, all of which are listed on the agenda. You may also submit public comment in writing, either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting adjournment. If you wish to testify in person, please sign in at the table by the door and leave a business card so we have an accurate record of your name. If you do not testify, you may also want to sign in so there's a record of those who are interested in a particular bill in the case that we need to contact you later. To ensure an orderly flow of discussion, all comments, questions, and responses please must go through me. Also, committee members must be recognized by me before you can speak. Additionally, I ask presenters on Zoom video call to leave your cameras off and microphones muted until it's your turn to present or if I direct any questions to you. When testifying in person, please turn the microphone on and off to speak and off to listen so that we can avoid a nasty reverb. With that, we'll move on to our agenda. We have a work session on the agenda today. We've got 5 bills to work session. I'm going to go ahead and go through each of these briefly. I'm going to go ahead and start with Assembly Bill 24, and I will have Mr. Ashton go over the bill.
Thank you, Chair Peters. For the record, Patrick Ashton, Committee Policy Analyst of the Research Division LCB. Just a reminder, as nonpartisan staff, I can neither advocate nor oppose any measures that you will consider today. Committee members, you should have received the work session document by email. You can also find a binder on your desk, and the work session document is available on Nellis. We will begin the work session with Assembly Bill 24, sponsored by DPPH, which you heard on February 22nd. AB 24 adds a member to the Committee on Emergency Medical Services who is appointed by the committee and who is employed by or volunteers with an agency, organization, or other operator that provides emergency medical services on tribal land. Chris McCann, EMS Chief, Elko County Ambulance Service, proposed conceptual amendments to Section 1 of AB 24, and see also the attached letter of intent in the work session document. Number 1, delete amended language in subsection 1 and instead increase from 9 to 11 the number of members appointed by the State Board of Health to the committee. Number 2, add to subsection 3 one member who is employed or serves as a volunteer with a third service governmental agency under certain conditions. Number 3, revise subsection 4 to require the State Board of Health, instead of the committee, to appoint to the committee one member who is employed by or volunteers with an agency, organization, or other operator that provides emergency medical services on tribal land. And number 4, make conforming changes for the other subsections as applicable. Madam Chair.
Thank you. Are there any questions from the committee members? I will entertain a motion to amend and do pass. Thank you, Assemblyman Nguyen. And I have a second from Assemblywoman Gonzalez. Are there any comments or questions on the motion? All in favor, please signify by saying aye. Aye. Any opposed, nay? Motion passes. Please proceed. Oh, I'm going to assign the floor statement to Assemblywoman Gonzalez. Thank you so much. We'll move on to AB 40.
Thank you, Madam Chair. For the record, Patrick Ashton, LCB. Assembly Bill 40, which was heard on February 22nd, requires the inclusion of an electronic mail address in an application to a health authority for a permit to operate a food establishment, by which the health authority may communicate with the applicant and send any inspection report form or other notice. Amendments. Cody Finney, Deputy Administrator at DPBH, proposed the attached amendment during the bill hearing. The intent is to authorize, but not require, electronic communication via email between food establishment applicants or operators and health authorities, except for notices related to the suspension or revocation of permits that must not be provided via electronic communication. Chair Peters.
Thank you, Mr. Ashton. Are there any questions from the committee? I would entertain a motion to amend and do pass. Thank you, Assemblywoman Gorlow, and a second from Assemblyman Gray. Are there any questions or comments on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. Motion passes. I'm going to assign that one to Assemblywoman Newby. Let's move on to AB 138.
For the record, Patrick Ashton, LCB. Assembly Bill 138, heard on February 20th, is an HHS interim committee bill. It requires the director of DHHS to pay the non-federal share of expenditures incurred for certain behavioral health services that are delivered through evidence-based behavioral health integration models, including, without limitation, collaborative care management services. There were no amendments, Madam Chair.
Thank you, Mr. Ashton. Are there any questions from the committee? Seeing none, I would entertain a motion to do pass. Assemblywoman Newby with a motion and Assemblywoman Taylor with the second. Are there any questions or comments on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. Motion passes. And I'm going to assign that to myself. We'll move on to Assembly Bill 178.
For the record, Patrick Ashton, LCB. AB 178 was heard on March 10th. It extends from 1 year to 5 years the length of a permit issued by a health authority for the operation of an ambulance, air ambulance, or firefighting vehicle. The bill also requires operators to notify the permitting health authority about any change in ownership or control within 90 days after the change occurs. Amendments. During the bill hearing, Tom Clark proposed to amend AB 178 with the intent to reduce from 5 to 2 years the length of a permit issued or renewed by a health authority for an ambulance, air ambulance, or firefighting vehicle. Please see also the attached amendment. Chair Peters.
Thank you, Mr. Ashton. Are there any questions on the bill as amended? Seeing none, I would entertain a motion from Assemblyman Gray, a second. Assemblywoman Gorlow, any questions or comments on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. Motion passes, and I'm going to assign that to Assemblyman Gurr. Move on to Assembly Bill 215.
For the record, Patrick Ashton, LCB. Assembly Bill 215 was heard on March 6. It revises the residency requirements for a person to be eligible for appointment to the Nevada Silverhead Legislative Forum by decreasing from 3 years to 1 year the time a person is required to have been a registered voter in the senatorial district of the senator who nominates the person for appointment to the forum. There were no amendments. Chair Peters.
Thank you, Mr. Ashton. Are there any questions on the bill? Seeing none, I would entertain a motion to do pass.
Madam Chair, I'd like to make a motion to do pass Assembly Bill 215.
Thank you, Assemblyman Hafen. As I have a second from Assemblywoman Gorlow. Thank you. Any comments or questions on the motion? I didn't second, but that's okay. Oh, I thought I heard you second. Oh, I'm sorry. Can we scratch the second? And we're going to, Assemblywoman Thomas is who I heard over there. Sorry. Any questions or comments on the motion? Seeing none, all those in favor, please signify by saying aye. Aye. Any opposed, nay. The motion passes. Great. I am going to assign that to Assemblywoman Gorlow. Thank you so much. Breezing through this, folks. I want to take a moment to thank our sign language interpreter on the screen. Thank you so much for bearing with us as I speak rather quickly to get us through that work session. I'm going to close our work session agenda item and move on to, I just put my agenda away, our bill hearings. We have 3 bill hearings from Assemblywoman Brown May today, and then one from myself. We're going to go ahead and start with all 3 of Assemblywoman Brown May's bills, starting with AB 99. I will go ahead and open the hearing on Assembly Bill 99 and ask our sponsor to please come to the table. Please remember to state your name for the record. You may begin when you're side note, we are trying to move through 4 bills today, so I'm setting a little bit of a time limit on our presentations. I have approximately 15 minutes scheduled for each of your bills, but use them as you will. We'd like to be through all 3 of these bills by 2:30 if possible. All right, we're going to go ahead and get started. Please remember to state your name for the record. You may begin when you're ready.
Thank you, Chair Peters, Vice Chair, members of this distinguished committee. For the record, my name is Tracy Brown May, and I am the Assemblywoman currently representing Assembly District 42 in Clark County. I love that we have a time limit today. Thank you for that. And we will certainly do our very best to move through all of these bills expeditiously. I also want to give our great thanks to our American Sign Language interpreter who is with us here today and will be with us throughout the duration of this hearing. In particular, the last bill that we will hear is relative to the Deaf Commission. And so thanks for indulging us today and allowing us to have a heightened level of inclusion, I think, during today's meeting. Assembly Bill 99, you have an amendment to the bill that we're going to discuss today. So please disregard your printed copies as there is a conceptual amendment. Mr. Ashton should have received this conceptual amendment some time ago. This bill in particular is about helping to ensure that we are conducting studies to provide factual information, okay? So some background here. This bill requires the Director of the Department of Health and Human Services, otherwise known as DHHS, to take actions necessary to increase certain federally approved reimbursement rates, to consider annual cost of living increases, as well as Medicaid reimbursement rates. Now, we know the Division of Health and Human Services has literally thousands of rates, the Division of Healthcare Finance and Policy, right? So we've narrowed the scope of this just a little bit. The division currently is required by law to complete a comprehensive rate review for each of the Medicaid provider types to determine the current reimbursement rates and then accurately reflect the cost of those reimbursement rates. They identify for each provider type once every 4 years what the rates of reimbursement are. And then when Nevada Medicaid identifies the rate for reimbursement that's inaccurate, it recommends a recalculated rate that covers the cost of services to the director of DHHS, or covers the cost of services for the Division of Health and Human Services for possible inclusion in the Medicaid state plan. So as the members of this committee, I'm sure you understand the complexity of the Medicaid state plan and the numbers of rates that go into the state plan. We have a federally approved state plan for Medicaid that comes through the Division of Healthcare Finance and Policy in the state of Nevada and is approved federally for those reimbursement rates. There's a current problem that was identified during the pandemic with some of the providers who receive reimbursement rates through the state plan for Medicaid. And that when the director of DHHS here locally within the state approves a rate increase, that sometimes there's already a maximum allowable rate that's been identified in the Nevada Medicaid state plan that's been filed with the federal government. And so while we might, as a state, approve an increase in reimbursement rates, if the corresponding paperwork is not done with Medicaid federally, then providers cannot receive payment for the increased reimbursement rate. So this is an issue that was identified through the pandemic, in particular with disability support service provider organizations. And there was an emergency rate that was approved through DHHS and the Division of Aging and Disability Services for one-to-one supports for people who had high support needs. Although the state had done the increased reimbursement rate as a way to shore up the provider network and ensure sustainability in that service delivery model, the federal documentation was not filed to increase the maximum allowable reimbursement rate. And so there's just some ambiguity with regard to whose responsibility is that? How does that fall within the state of Nevada? And so, when working with DHHS and the Division of Aging and Disability Services and then the Governor's Office of Finance, it was just identified that we could perhaps delineate who the responsible party is to fill out the MAR, is what it's referred to, MAR, maximum allowable rate, paperwork with the federal government to increase the rates approved by the Nevada Medicaid state plan. That's what this bill does. So with your permission, I'll walk through that conceptual amendment.
Please go ahead.
Thank you. As you should have in front of you, item 1 is to amend NRS 422 to require the Division of Healthcare Finance and Policy to submit the report of its findings from the quadrennial rate reviews to the Joint Interim Standing Committee on Health and Human Services and the Interim Finance Committee, and it identifies the dates, so we're asking for the quadrennial rate review to be shared with the committees of the legislative body. And then to require the division to conduct a study to determine the cost of the state general fund of either increasing the rates of reimbursement provided to long-term care providers to account for the increase in the cost of living as compared to the date when the rate of reimbursement was most recently established. While we do quadrennial rate reviews, we don't always take into account inflation rates, right? And so we're not looking at rate reviews except for every 4 years because there's too many rates to review more often. And so this would have us look at potential cost of living increases to ensure that we don't lose control of the rates. And then annually adjusting the rates of reimbursement provided to long-term care providers to account for future increases in cost of living. We're only asking for information and recommendations. That's it. And then to require the division to compile the report summarizing its findings from the study that's described in item 2 and to submit the report to the Interim Finance Committee for the 83rd sessions, no later than November 15th, 2024. And the report must include recommendations necessary to effectuate an increase in reimbursement for long-term care providers. And this is the important part. This last sentence, including any statutory changes that are needed to authorize the director to implement such an increase and necessary federal approvals. That's the part that directs DHHS to complete the federally required documentation to increase the MAR should the state plan for Medicaid need to be adjusted. And then number 4 is the long-term care provider definition for the purposes of 2 and 3 to mean providers of home and community-based waiver services pursuant to NRS 422, and then any other providers enrolled in Medicaid that provide long-term care services to recipients of Medicaid, including residential and day provider organizations. And that in its entirety is the bill. Now, I do have with us in the audience, in case you have technical questions relative to how this would play out, is Marla McDade-Williams, the Deputy Director for the Division of Health and Human Services here in Nevada. And that is, I'm happy to stand for questions.
Thank you for the presentation. And just to clarify for the committee, we're talking about Medicaid, which is a very complex financial insurance institution in the state without the administrator of that. Some of our questions may not be able to be answered today, but I will open up for questions. Are there folks who have questions on the bill in front of us today? I had a quick question for you on the date for the quadrennial review process. Is that in line with how those dates currently align, or how did you pick that January 31st date?
Assemblywoman Tracy Brown May, for the record. Yes, Madam Chair, they are currently in alignment with what the division has recommended for what's in process for their existing quadrennial rate review process for these rates.
And this would require, I'm looking at point 2 and 3. I just want to clarify for the record, this is a one-time study request that will be completed by the end of next year or a little bit before the end of next year. And just so the committee knows, we generally, are we on 23? That is after the interim committees submit their bill requests, which is that August deadline. Can you just talk a little bit about why we picked November?
Thank you, Assemblywoman Tracy Brown May, for the record. That's a really great question. So historically, this is meant to address a historical issue relative to the need to correspond the federal maximum allowable rates with rates approved by the division to cover the cost for Medicaid services, right? And so let me walk it back. I'll give you a good example, which I think could probably give a little bit of the detail. Some of the provider rates, let's just go with the rate I know the best, right? The intellectual disability rate. So the intellectual disability rates, the rate study was completed in 2002. And from 2002, there were incremental rate increases that were done for that provider rate type. But then when the rate review finally came to pass, the rate reviews are done over a period of time and recommendations are made for our Medicaid state plan, okay? When the next rate study came around, it was right before we went into pandemic, and the rate study identified a rate deficiency of a significant percent. It was about 26.9%. And so we finally get a rate study, but we've never looked at COLA throughout the period of time, right? And so really this is about getting us to shift how do we look at what are our rates within the state, how do we look at what the cost of a rate is, and how do we figure inflation in. And so while this might not necessarily affect the next biennium and the next budgeting, it's going to get us a lot farther ahead than 2002 to 2022, right? So really it's about shifting how do we look at the rates to ensure that we're accounting for some cost of living as we go forward. I hope that answers your question.
Thank you. That helps to clarify. I have another question from Assemblywoman Newby. Please go ahead.
Thank you, Madam Chairwoman, and thank you, Assemblywoman, for bringing this bill. With the amendment, I noticed that it's restricted down to the long-term care providers, but I'm wondering if this systemic issue that you've identified with there being confusion about who needs to file the necessary paperwork, does that exist for other rates and other aspects? Because if it does, it seems like it's more of a systemic issue.
Thank you. Tracy Brown May, for the record. That's a great question. With your permission, I'd like to defer to Ms. McDade-Williams, who's here, as she could potentially answer that question more accurately.
Thank you so much for being here as an expert from DHHS, Ms. McDade-Williams. And please let us know if we need to hold the question to follow up with your office.
Thank you, Madam Chair. For the record, Marla McDade-Williams, Deputy Director, Department of Health and Human Services. So that is not a question that I actually have an answer for. In fact, this whole discussion is brand new to me. I hadn't, it was not in the forefront of my mind. I'm prepared to answer questions about the quadrennial rate review and the fact that, yes, we do review rates, and really we propose those in our budget, right? Sometimes we propose them, sometimes we don't propose them, but they are out there for people to see when we do the rates. You are correct that it is a much broader discussion as it relates to the process that we use for conducting the rate reviews, right? Are we in some cases, we're looking at surrounding states and assessing rates in the surrounding states and then determining what rate we want to move forward. If the legislature determines they want us to be looking at the higher rate and not some median rate or some lower rate, we could benefit from having that type of direction in the overall process. We could benefit from having direction about what we put in our budget or do not put in our budget based on the rate reviews. But the process, the internal process, I'm not actually certain how, definitely legislation directing us to make sure that we follow the process isn't going to hurt anything, but I'd like to actually do more work to find out how that is actually working, because that doesn't really make a lot of sense to me about why we wouldn't follow something through the process unless it was a timeliness issue, but I will get back to you on that piece.
Thank you. We appreciate the availability for a follow-up from there. Assemblywoman Thomas, would you like to ask a question?
Thank you, Madam Chair, and thank you to the Assemblywoman for bringing this presentation to us. I think that it is worth looking into, but my question actually has to do with the CPI. You know, for the western states right now, currently I believe it's 5.6. Are you looking at that when you're looking at your rates to adjust for payments to doctors?
Madam Chair, if I may respond, Marla McDade Williams.
Please.
My
thank you.
understanding is that we are looking at other states and the rates that they're paying, and then assessing the rates that we're paying, and then determining a rate that we move forward. So if those other states are including CPI in their rates, then it's likely that the rate that we end up looking at includes that. But I would actually have to go back and do, again, more specific research to see what other states are including CPI in their rate reviews.
I would really appreciate that. I think we would have an accurate assessment. Thank you.
It's a good follow-up. Thank you so much for that. Are there any other questions from the committee before we move into testimony? Thank you both so much. We really appreciate you being here, Ms. McDade Williams, and thank you to the Assemblywomen. All right, we will move into support testimony for Assembly Bill number 99. I'm not going to limit individual testimony, but just let you know that we are trying to limit testimony in total to approximately 10 to 15 minutes. So I'm going to invite those in support in both Carson City and Las Vegas, and we'll move to the phones. Looks like we have someone. Please remember to state your name for the record. You may begin when you're ready.
Good afternoon, Chair Peters, members of the committee. My name is Jimmy Lau with Ferrari Reader Public Affairs, first name Jimmy, last name Lau, Lau, representing Dignity Health St. Rose Dominican and Quest Diagnostics today in support of this bill. Thank you.
Thank you. Please remember to state your name for the record. You may begin when you're ready.
Madam Chair and committee members, my name is Sarah Cummings, and I'm on the executive. You said spell it? I'm sorry.
Unless we got your card. If we got your card, you're okay.
And I am on the executive board of the State of Nevada Association for Providers. SNAP's 22-member organization are in full support of AB 99. The bill requires the state to conduct regular review of Medicaid rates in relation to federal cost of living adjustments. These rates in dollars pay providers such as those in SNAP to meet the needs of services for individuals with intellectual disabilities. Our provider network employs thousands of Nevadans to support individuals. A passage of this bill is essential to sustain these important services.
Thank you for your testimony. We're going to go to Las Vegas. Please remember to state your name for the record. You may begin.
Thank you, Madam Chair and members of the committee. My name is Ricky Guri of TriStar Energies, here representing Opportunity Village. Opportunity Village agrees with the language of AB 99 and would like to thank the Assemblywoman for bringing this legislation forward. We believe in supporting this legislation because this will create a great tool that will empower the department to modernize rates so providers like Opportunity Village can continue serving vulnerable populations that need services. Thank you for your time.
Thank you for your testimony. Is there anyone else in person who would like to testify in support? Seeing none, I'd go to BPS. Please check the public line for support testimony on Assembly Bill 99.
To testify in support of Assembly Bill 99, please press star 9 to take your place in the queue.
Good morning, Chair. Good afternoon, Chair and the committee. This is Dora Martinez, representing the Nevada Disability Peer Action Coalition. I hope you are all able to hear me. I'm in a bus. Thank you to the sponsors, and we appreciate this bill and we support this bill. Thank you.
Thank you for your testimony. Are there other callers on the public comment line for support testimony?
Caller, you are
Good
unmuted.
afternoon. Thank you. Good afternoon, Madam Chair, Mr. Vice Chair and Committee. My name is Zach Bucher, Z-A-C-H, B like boy, U-C-H-E-R with the City of Las Vegas. We are here today in support of AB 99. The City of Las Vegas, especially Mayor Goodman and our City Council, have long championed the idea of increasing Medicaid reimbursement rates in an effort to attract and retain quality medical providers in our community for our residents. This bill would help address this exact issue while making sure we stay on the good side of the federal government. We are thankful for the sponsor for bringing this important legislation, and I would just like to say thank you, Madam Chair, and wish everybody a happy St. Patrick's Day. Thank you. Bye now.
Thank you for your testimony. Are there other callers on the public line for support testimony today?
If you have recently joined and would like to testify in support of Assembly Bill 99, please press star 9 to take your place in the queue. Caller, please press star 6 to unmute your phone.
Good afternoon, Madam Chair and members of the committee. My name is Marlene Lockard, representing SEIU 1107. We are very much in support of this bill and thank the Assemblywoman for bringing it forward and identifying and bringing a solution to a long-term problem within the system. We hope this is the beginning of parity throughout the Medicaid plan. Thank you so much.
Thank you for your testimony. Are there other callers on the public line for support testimony?
Chair, there are no other callers to testify at this time.
Thank you. We'll go ahead and move into opposition testimony in our physical locations in Carson City and Las Vegas. If you are prepared to present opposition testimony on Assembly Bill 99 today, please come up to the desks. Seeing none, I'd ask BPS to check the public line for opposition testimony on Assembly Bill 99.
To testify in opposition to Assembly Bill 99, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you so much. We'll move into neutral testimony. Is there anyone in Carson City or Las Vegas who'd like to provide neutral testimony on Assembly Bill 99? Please remember to state your name for the record. You may begin when you're ready.
For the record, Madam Chair and committee members, Connie McMullen representing the Personal Care Association of Nevada. I wrote testimony initially in favor of this bill, and then I read the amendment, as I did last time I was here. It kind of changed my opinion. I support what the bill brings, but personal care is non-medical, but we work with all of these waivers and provide services to all these populations from the lifespan to death. And we believe that we should be included when they look at reviewing the rates, and with the cost of living, it's a great idea. But we should have been included. We are all listed among that category under facilities of the dependent in our license, and we should be included with all of these. And when they decide if they're going to change a rate for those who are providing long-term care and supports, which we also do, we should be included. And if not, maybe we should be out of the facilities for the dependent and be held to a lesser standard in our licensing. Thank you.
Thank you for your comments. It sounds like it would be worth having a conversation. Are there any other folks who would like to present neutral testimony in our in-person locations? Seeing none, BPS, will you check the public line for neutral testimony on Assembly Bill 99?
To testify in neutral for Assembly Bill 99, please press star 9 to take your place in the Chair, there are no callers to testify at this time.
Thank you. With that, I would invite the bill sponsor for closing remarks. None there. We will go ahead and close the hearing on Assembly Bill 99 and open the hearing on Assembly Bill 100. I would invite the bill sponsor up and any co-presenters she may have. Please remember to state your name for the record. You may begin when you're ready.
Thank you, Madam Chair, committee members. I just have to say, this is really fun today. I never get to do 3 bills in a row, so thank you for allowing us the opportunity to do this. Are we good on time? Are we okay? Okay. For the record, my name is Tracy Brown May. I'm the Assemblywoman representing Assembly District 42. It's great to see you again for bill presentation number 2 today. We're here to talk about Assembly Bill 100, so thank you again for the opportunity to do this. Joining me today is Molly Walt. She's the chairwoman of the Nevada Lifespan Respite Care Coalition, so you have to slow down in order to say that. Also in our audience today, I want to draw your attention to directly behind me is Cheryl Donnell. She's here to address specific questions, should we have any. She's the executive director for the Nevada Lifespan Respite Care Coalition, and her son is also with us. Eric, as you can see, she is a caregiver herself. Again, I want to draw your attention to the amendment, which is available on Nellis. And so that's the piece that we will be walking through, is the proposed amendment to Assembly Bill 100, as there's been a great deal of work done there. So by way of background, family caregivers are an integral part of providing adequate care to individuals with care needs in our communities, right? And many of us are caregivers to our family members, and it's important that we develop ways to support caregivers. Throughout the pandemic, it was identified that our caregivers are more needed than ever before in our history. Some of us care for people with health conditions, disabilities. We provide personal care. You heard how important personal care is earlier. We complete household chores. And some of us, it's just emotional support, right? There's a lot of complexity to being a family member, and how do we care for the people that we love? COVID-19 brought an increased level of expectation and work on our family caregivers, and too often we don't know who they are. So it's important that we focus on improving the support resources available to our caregivers. In order to do that, though, we have to figure out who and where they are so that we can build the support systems around them. And I'd like to introduce you to Molly, and she has a number of things she'd like to talk to us about, with your permission.
Please remember to state your name for the record. Thank you for being here.
Thank you. Good afternoon, Madam Chair and members of the committee. My name is Molly Walt, Chair of Nevada Lifespan Respite Care Coalition, NLRCC. I'm honored to be here to present Assembly Bill 100, and thank you to Assemblywoman Tracy Brown May for sponsoring this bill. NLRCC's mission is to support caregivers in our community by promoting awareness to access to, coordination, and advocacy for respite services in Nevada throughout the lifespan. We strive to bring awareness and acceptance to respite care as a typical experience and valued service, and that the service fits the need and choices of the consumers. The coalition is comprised of representatives from across Nevada's private public sectors, as well as family caregivers. As there are unpaid caregivers, there is no training. Many caregivers are not mentally or physically prepared to become caregivers, let alone financially stable. Existing systems such as long-term services, healthcare, and other services must take notice of these needs and ensure that family caregivers are offered support and services to protect their own well-being. This can only be done by recognizing family caregivers and the role that they have in ensuring positive outcomes for their loved ones. Currently, Nevada does not have a system to recognize a caregiver's role, such as assessments to address the health and well-being of that family caregiver, even at logical points such as hospital discharge planning. Being a caregiver myself, I can personally testify to the importance of caregiver assessments. My father and I had absolutely no idea caring for my mother would be so difficult. The doctors, hospital, and rehab facilities sent my mother home with an elderly father with no instructions on how to care for my mother, and did not speak to him about the physical demands of caring for mom would be. In recognition of the pressures and demands of caregiving, there are several national initiatives that emphasize the importance of caregiver assessments. It is important that the caregiver assessment be required to acknowledge and support the needs of informal family caregivers and facilitate the individual's linkage to needed support. The Older Americans Act has been amended to allow the caregiver assessments in the National Family Caregiver Support Program, allowing agencies to utilize assessments in the determination of services to be provided. We need to know who these caregivers are. The Centers of Medicare Guidance on the Balancing Incentives program also acknowledges the importance of caregiver assessment. CMS recommended that family caregivers needs to be considered as part of the best practices, recognizing that families and/or caregivers often have needs outside of the specific need of the individual eligible for the service. These needs are typically connected to caregiver stress, a need for information and referral, support groups, and/or respite care. An assessment process that incorporates components tied to caregiver needs will result in a more well-rounded assessment of the service and support needs for the whole family. The purpose of this legislation is to establish a process to be incorporated into the service systems to assess caregiver willingness, ability, and needs to provide care. The legislation also requires data from these assessments to be reported and used for planning for caregiver support systems throughout the state. This is the first step.
As you heard Molly say, this assessment really is the first step. Caregiving can be overwhelming, stressful, isolating, can cause additional complications to our family members that we're not prepared to deal with. And the lack of data on the capabilities and the needs and the quality of life of our family members is really driving this bill. And now this bill is the compilation of ideas that came out of many meetings during the interim with the Lifespan Care Coalition. Like, this is a group of people that are here to support our family members in providing care, to identify who our caregivers are. It's only the beginning of the process. My mom and dad live in Florida. My dad is 90, and my mom is 86, and she has advanced Alzheimer's. A 90-year-old man is her primary caregiver. Nobody knows that who is in Florida. There's nobody in Florida that knows there's a woman 100% dependent on a 90-year-old man. So if something happens to him, what happens to her? And so that's so many of our families are affected by this, right? Until we know who our family caregivers are, we can't build the support systems around them. So with your permission, I'll walk you through the bill.
Yes, the amendment, yes?
Yes, correct.
Yes, please go ahead.
Thank you for clarity. Tracy Brown May for the record. Okay, so the summary, this is about providing a study relating to caregivers for the Division of Health and Human Services to develop and implement a pilot program. So this is not ongoing, this is a pilot program to administer assessments to family caregivers, directing the department to certain studies relating to caregivers. Okay? So number 1, Section 1.1, the Department of Health and Human Services shall during this next interim develop evidence-based and culturally sensitive assessments to be administered to family caregivers by the division. There are a number of examples that exist in states across our country, so we don't have to recreate the wheel. The idea is to determine the willingness and ability of our existing family caregivers to continue to provide long-term support services, which costs us less money if we can keep family caregivers caring for their family members. And then to measure the extent and quality and value that the effect of those social determinants of health and those risk factors that are related to stress and depression are having on those family members. We also want to establish a process for gathering the data collected through the assessment that's developed pursuant to this section, and then develop and implement a pilot program to administer the assessments, which the division feels confident that they have the ability to do, so that this would be administered through the Division of Aging and Disability Services for existing waiver participants, so all of the folks that are currently receiving home and community-based services waiver supports through the Division of Aging and Disability Services would become part of a pilot program for this caregiver assessment to identify who our caregivers are and what are the quality questions we want to ask them to determine where they are. And then on or before June 30, 24 and then June 30, 25, the department will compile the report concerning the data that they have collected, and then they will publish the report on a website and then issue it to this legislative body, the Nevada Lifespan Respite Care Coalition, the Commission on Aging. So they will take all of those informed data and deliver it to a number of coalitions and boards to assess the data. And there was an initial large fiscal note because we wanted to really do this for everyone who was being discharged from a hospital setting. But we don't have the pilot program stood up, so we don't even know what the assessment should look like until we do this pilot initial study. The fiscal note has been significantly reduced. The division is amenable to launching this pilot program, and that's where we are. I stand for questions.
Thank you so much. We have a couple of questions. I'm going to start with Assemblywoman Gonzalez.
Thank you so much, Madam Chair, and thank you so much for the presentation. And I may have missed it, so it could just be a clarifying question. So you stated that we don't know, or the problem is that we don't know who is being a caregiver, and this bill would enable a study, but it doesn't, it just says enable and development of programs. So do we have any idea of how we would find these caregivers? And I think you may have just said, I honestly think I just missed your last sentence, so I just wanted clarification. Thank you.
Thank you. Assemblywoman Tracy Brown May, for the record, that's a really great question. You're absolutely right. So in clarifying, and I don't know that the conceptual amendment really identifies it well, but the concept that we're working on currently is that every person that is served through the Division of Aging and Disability Services on a home and community-based services waiver, it currently comes through the Division of Aging and Disability Services, would become part of this initial pilot study. And so the reason that that's necessary is that many of our HCBS programs serve adults, right? And while they might be an adult with a developmental or intellectual disability or other disability, they're adults. So we don't often look at who is a caregiver for an adult, because they should be their own guardians in many instances. This pilot program would enable ADSD to look at families differently in a holistic fashion to identify who's really giving care, who are our caregivers in our society. So then we can begin to flesh out what is the data we need to identify, and then how do we track it. So the pilot program would start just with ADSD, home and community-based services, waiver recipients being served by that division.
And just a clarification, Chair, if I can, that certification, can you just talk about what that is for those of us that don't know? Thank you.
Assemblywoman Tracy Brown May, for the record. Absolutely. The Division of Aging and Disability Services works with the Division of Healthcare Finance and Policy in an interlocal agreement. ADSD currently operates 3 waiver programs, home and community-based services waiver programs, that serve certain populations. So we have the physical disability waiver, the intellectual and developmental disability waiver, and the frail and elderly waiver. And those 3 waiver programs you have to qualify for through the Division of Aging and Disability Services in order to receive the services that are identified in each of those programs. And so because we have those 3 specific populations already delineated under our home and community-based services waiver, the goal for HCBS is to keep people in the community, not in long-term care facilities, not in hospitals, right? We want to keep people in our community. So by going through the HCBS programs that exist currently, we have an opportunity then to consider what's the next program to develop to keep people in the community with a high level of support.
Thank you. Assemblywoman Taylor, I have you next.
Thank you, Madam Chair. And thank you again to the Assemblywoman, and thank you for being here. I too am a caregiver of my mom, so I really applaud the efforts in this. And it just is also going to be clarifying, because I think it's clear, but I wanted to be sure, is the target on this to find those who are caregivers that are recipients when the person being cared for is a recipient of Medicaid, or are we trying to really get an assessment of everyone across the state?
Thank you for that question, Assemblywoman Brown May, for the record. Initially, we're going to have to start with a small pilot population to identify what is the data we need to gather to be able to develop the support systems. Eventually, we should be able to do this assessment for everyone, and we're going to have to figure out what's the right entry point to make sure that every family is able to identify whether they're a caregiver and how do we get them the long-term support they need to keep their family healthy.
If I may follow up, Chair? Thank you very much. So for the pilot, it will just be targeted towards those who are recipients of Medicaid for the pilot, but the whole idea is it is a pilot, which will give a reflection. And again, I don't know if there's So thank you, you've made that clear. I don't know if there's a way to find those who are not in Medicaid, 'cause there's no way, you don't have to sign up or anything, but that may give us different data if we're looking at those who have patients, who are caring for patients who are not in Medicaid. So if there's a way to have some inclusion in that from the pilot, again, that may provide some other data, so something to consider.
Assemblywoman Brown May, for the record, thank you. That's a great suggestion. I certainly look forward to working with other proponents of this bill to continue to expand the scope so that we can further identify caregivers in our community. Thank you.
Thank you very much. Thank you, Chair, and thank you for bringing this forward.
Thank you. I have Assemblyman Hibbets and then Gray next, and we'll move to testimony after that.
Thank you, Chair. So I'm just trying to clarify here. I'm going to truncate some of what the amendment says, the amended bill says. It says that in Section 1, Department of DHHS during the interim shall conduct culturally sensitive assessments be administered to family caregivers by the division. Such assessments must. And if you go to number 4, it says, assess the capacity of each caregiver to provide all necessary care, including without limitation any activities of daily living and instrumental activities of daily living, which is good. When you refer to the letter that you provided all of us, which, by the way, thank you very much, that made it much simpler, under AB 100, it says, as a state, we are unable to identify who our caregivers are. So if we are unable to identify who our caregivers are, how are we going to survey them? And if we are unable to identify who our caregivers are, if we could survey them, how does the division know that they could use the pilot with the existing personnel and have any idea how much this could cost?
Assemblywoman Brown May, for the record, thank you for those very informed questions. I sincerely appreciate the detail. So you're right. Right now, we can't identify who they are, so we've gone to people who specifically need care that we know of to begin to identify what questions we're going to ask, which is that Medicaid care population. Ideally, if we could have done what we wanted to do in this initial rollout, we would survey every patient in a hospital setting. That's what we would do, because it starts with a level of care. Unfortunately, we don't even know what the questions are to ask yet, so we can kind of figure out where to go to start to identify who needs care, but we don't have the mechanisms in place within the state to do that, which is why this pilot program is essential. So that will begin to help us to identify who they are. And as a good example, folks with intellectual and developmental disabilities are considered adults who are their own guardians. Many of them have caregivers that have not been identified by the division because we don't ask those questions, because we're serving adults. And so now this gives us the opportunity to ask those questions. We are directing the division to start this pilot program, which they've agreed to and feel like can be funded by grant dollars, right? They're amenable to this. They agree we need to do this. So this cost will be significantly less than if we were to roll out a program that we didn't know how to roll out across the entire state. Eventually, we would like to step through that process. So this is how we begin to identify who our caregivers are.
I have a quick clarifying question for your question. Were you asking about how much would it cost the state to cover these caregivers, or are you asking how much it would cost to run the study and pilot program?
I was referring to the cost to run the program, not the coverage. My follow-up is, you indicated that the division is amenable to this. They want to do it. They think it's good policy. Is there a specific statute that's preventing them from doing this now?
That's a great question. Tracy Brown May, for the record, not that I'm aware of, not other than they have not been directed to do that currently, right? So the Caregiver Coalition is the one that brought forward the recommendations to the division. And so by giving them the authority to be able to do that study, then we bump it up on the priority list. But I don't have that answer. I'm happy to track that for you.
Well, my only concern there is if there's nothing preventing them from doing it, why don't they just do it and we don't need to pass another law?
I appreciate the question. This is the process that we go through in having and engaging the resources at the state from the legislative level. I'm going to go ahead and move on to Assemblyman Gray.
Thank you, Madam Chair. This is one of those things, the way I'm looking at it, the best of intentions, But, and one of the first sentences in the proposed law is, culturally sensitive. I took care of both my parents. I actually had my dad living with us for quite a while. It would be a cold day in hell before I would have somebody come in and assess the way I am taking care of him. And I don't know, it's our responsibility as family members to take care of these people. And you guys said you need to know who they are. And I'm just not seeing where the state has responsibility in this, especially when you're mandating it for recipients of the waiver. I mean, if they're asking for help or, or reaching out, that's great. But I just have a hard time with the government thinking they need to know this information. I just have a real hard time with it. I'm waiting for you to sell me on why it's a really good idea.
Assemblywoman Brown-May, for the record, thank you for the statement. I could respond in many, many ways. This is not the government saying that you are going to be assessed in how the quality of care is that you're providing for your family. But it certainly would be our ability to stand up a program to walk alongside you in that care. Because as a caregiver, I know how stressful it is, and the hours, and the unwillingness of families to have to lean on someone for help. But you know what, if the nurse knocked on my dad's door today and said, I'm the nurse here and I'm here to help, how can I help you? He's gonna let her in, but I need to know he's there, right? And so it's really about shoring up our families to be able to keep your family in your house longer at a higher quality of care without having to go to a long-term support care setting, right? There's going to come a day when my mom is probably going to have to be moved into a long-term memory care, and that's going to devastate my dad. So this is not about taking control, and I'm going to get emotional because it's really personal. It is about identifying what he needs and what all of our family caregivers need to keep their people at home and safe and fed and have quality care, and for us to provide the programs to walk alongside you to continue that, because every family deserves to be served at home. And until we know that families need help, we can't serve them. So that's really what this is. It's not about taking your power away. It's about giving you more power to keep your family member at home.
Just real quick follow-on statement, ma'am.
Please keep it brief. We're going to move
Thanks.
into testimony.
Yeah, and I appreciate that's a much better answer than I've heard so far, but I still question the mandating it. Why not make it voluntary? I mean, I think you'd get far better answers and far better participation, so.
Thank you, Assemblywoman Brown-May, for the record. We're not mandating that families participate in this study. We're mandating that the division roll the study out to help to identify who those caregivers are. So if somebody refused to fill out a study, nobody's going to twist their arm and make them do it.
There's no added misdemeanor in this bill for not participating. Okay. Okay, I had a very kind request for one last question. I'm going to go ahead and let Assemblyman Hafen go ahead and ask a question, and we'll move into testimony.
Thank you. Thank you, Madam Chair. And thank you for bringing this forward. I think most of you know my family dynamics, and I know that when my father spent months in rehabilitation, my mother was there by his side, getting this kind of training that you're discussing on how to help prevent our own injuries and how to deal with the mental stress that goes along with everything. So I think that some of the comments have kind of gotten like we're trying to just take care of like grandma and grandpa, but that's not what we're doing here today. And I just want you to clarify it. We're talking about people with serious disabilities that needed additional assistance, whether it's mental or physical, and not just taking care of our older generation. Could you just clarify that I'm seeing this correct, and that it's also completely voluntary?
Thank you, Assemblywoman Brown-May, for the record. Thank you for that clarifying question. That is, first, 100%. It is completely voluntary. And yes, it is about taking care of people who have high support needs, and how do we walk alongside them to help them with that. And I just want to draw your attention to Cheryl Donnell, who is the executive director, and she's very patiently sitting here with her son, Eric, right? Eric is a person who receives services through the state division, and we don't know that Cheryl is here. As she's the caregiver, our primary caregiver, but most recently Cheryl's husband, if I can share a bit of your story, has had a stroke. And now she's the primary caregiver for her husband at home and her son, her adult son with a disability, right? And so how do we walk alongside Cheryl to make sure that we know she's there, and how do we help her? So it really is about that additional training and support that we can provide to families to help keep them whole in their homes.
Thank you. We'll go ahead and move into support testimony on Assembly Bill 100. We'll go ahead and start here in Carson City, and we'll move to Las Vegas and then to the phones. Are there folks who would like to present support testimony on AB 100? Please remember to state your name for the record. You may begin when you're ready.
Connie McMullen, and I'm speaking on behalf of the coalition, or rather the Commission on Aging, under Aging and Disability Services Policy Subcommittee. I'm a member of that, and having sat on 4 strategic plans in the state over the past 20 years and an Olmsted update, I think this would be great. This kind of information is needed, and oftentimes caregivers often succumb to disability and possibly losing their life caring for a loved one, and it's difficult. It's difficult business, and we would like to know, sure, all those details, because I'd like to see them personally get paid. Anyway, that's what I have to say, and if on the personal care side, the association that I represent, oftentimes we do take care of intermittently those family caregivers, and you can assess us and ask those questions of us anytime. Thank you.
Thank you for your testimony. Please remember to state your name. You may begin.
Madam Chair and committee members, my name is Sarah Cummings, and I am on the executive board of SNAP, the State of Nevada Association for Providers. Our member organization provides services to intellectually disabled individuals throughout the state. SNAP supports AB 100 because every day we see how important family caregivers are in meeting the needs of these individuals. They play a crucial role in the continuum of care that the disabled individuals may require. Assuring that caregivers feel supported and have complexity needs to provide the care for their loved ones is extremely important, not only to the individuals being cared for, but also for their caregivers. Thank you.
Thank you for your testimony. We will move to Las Vegas. Please go ahead and state your name for the record. You may begin when you're ready.
Chair Peters and members of the committee, my name is Maria Moore, State Director for AARP Nevada, and here representing our 347,000 members here in the state. Support for family caregivers generally, and caregiver assessments in particular, are a top priority for AARP. That's no secret. Improving and expanding access to caregiver needs assessment is one of the top priorities outlined within AARP's caregiving guiding advocacy principles. Family support is often essential for helping older people and adults with disabilities continue to live at home and in the community. Yet, the work of family caregivers can be demanding, physically, emotionally, financially. If caregiver needs are not assessed and addressed, their own health and well-being may be at risk, which may lead to burnout, jeopardizing their own ability to continue providing care in the community. The decline in caregiving self-reported health is concerning and indicates that support for caregivers and their recipients will be even more critical. Providing high-quality care often also requires an understanding of the family caregiver situation, because caregivers who cannot care for themselves may become unable to care for others. For these reasons, family caregiver needs assessments are an important component of a person and family-centered care planning process at home and in community-based services. We support the proposal by Assemblywoman Brong May to develop a culturally competent family caregiver assessment needs. We urge the state to ensure that the assessment reflects the varying experience and needs of the diverse communities within Nevada, and ensure that the needs assessment measures not only the ability of the family caregivers, but also identifies the needs and challenges specific to what caregivers are facing, and those needs may be addressed within new or existing programs. Thank you for the opportunity to testify, and thank you, Assemblywoman Brong May, for bringing this important legislation.
Thank you for your testimony. We'll stay in Las Vegas. Please go ahead when you're ready.
Good afternoon, Madam Chair, members of the committee. Ricky Gourier with Tri-Strategies on behalf of Opportunity Village. We are here today in full support of this legislation because we understand how important it is to do this study and pilot program to identify family caregivers across our state. Thank you for your time.
Thank you so much. Is there anyone else in Las Vegas that would like to present support testimony today? I don't see any approaching the desk. BPS, I would ask that we check the public line for support testimony on Assembly Bill 100.
To testify in support of Assembly Bill 100, please press star 9 to take your place in the queue.
Hello again. This is Dora Martinez, representing the Nevada Disability Peer Action Coalition. We ditto the prior commenters, and thank you for the sponsor for this bill. Thanks.
Thank you, Ms. Martinez. Are there other callers on the public line for testimony on Assembly Bill 100?
Caller, please.
Good afternoon, Madam Chair and members of the committee. My name is Marlene Lockard, representing SEIU 1107. We are very much in support of this legislation, AB 100. We have been working tirelessly to improve the quality of life for personal caregivers and believe this data is essential as Nevada is one of the fastest growing senior populations, and the need for more and more caregivers is paramount. We need to know where we are and what the full need is in our state. Thank you very much.
Thank you. Are there other callers on the public line for support testimony?
Chair, there are no other callers to testify at this time.
All right, we'll move into opposition testimony. Is there opposition testimony in Carson City or Las Vegas? Seeing none, BPS, is there anyone on the public line for opposition testimony on Assembly Bill 100?
To testify in opposition to Assembly Bill 100, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you so much. Is there anyone in Carson City or Las Vegas for neutral testimony on Assembly Bill 100? Seeing none, BPS, is there anyone on the public line for neutral testimony?
To testify in neutral for Assembly Bill 100, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you. I'd invite the bill sponsor up. She's waving. We'll go ahead and close the hearing on Assembly Bill 100. We'll open up the hearing on Assembly Bill 206. I will invite the sponsor up. Please proceed when you're ready. We are on a bit of a timeline now, but I think that this one can go relatively quickly. Please go ahead when you're ready.
Thank you, Madam Chair, members of the committee. Assemblywoman Tracy Brown May for the record. Again, thank you for this great opportunity to present 3 bills to you on this Friday afternoon. We're doing our best to keep them moving along, and so I appreciate your time and your attention. This bill is actually the bill. We have no amendments. This is the actual bill that you have, which is really fun, right? So this bill is very simple. It adds a 12th member to the Nevada Commission for Persons Who Are Deaf or Hard of Hearing. It's really why we have made sure that we've invited our sign language interpreter here today. And this bill also requires that the member be registered with Nevada's Aging and Disability Services Division as an American Sign Language interpreter. Before we walk through the bill, though, I would like to introduce you to Eric Wilcox. He is the chair of the Nevada Commission for Persons Who Are Deaf or Hard of Hearing, and he's going to help to present AB 206 today and provide some background information.
Thank you, Assemblywoman Brown May, and thank you, Chair Peters and members of the committee for the opportunity to speak with you today. For the record, I am Eric Wilcox. I'm the parent of a deaf child, and I am currently chair of the Nevada Commission for Persons Who Are Deaf and Hard of Hearing. Before I give some brief background comments, let me add my thanks for having the sign language interpreter here for this entire session and for having it split screen here in the room. I would encourage the technical services here to make sure that the split screen appears consistently through the entire hearing on the live stream, because I'm not sure that that may be the case today. So that's some room for improvement. The Nevada Commission for persons who, the mission of the Nevada Commission for persons who are deaf and hard of hearing is to ensure that all Nevadans have equal and full access to resources, services, and opportunities in all aspects of community life. It's the goal of many disability advocacy groups to improve educational opportunities, access to communication, and improve representation for people who are deaf and hard of hearing. Currently, there is no seat on the commission reserved for an ASL interpreter, and this presents a lack of representation and support for the very community that the commission seeks to serve. For the deaf community, ASL is for many in the deaf community, ASL is their language. ASL is a key pillar of deaf culture, and it's central to the identity of many in the deaf community. ASL interpreters must be fluent not only in the language of ASL, but they must be fluent in deaf culture and attuned to the dialects and expressive preferences of the individuals that they're serving. ASL interpreters are vital for ensuring access in all aspects of public life for deaf individuals, and as such are an accessibility afforded to the deaf under the Americans with Disabilities Act. In the past 5 years, the Deaf Commission has conducted a series of town hall meetings with the deaf and hard of hearing community across the state. One consistent element of feedback that we've heard from every community is that there is a large deficit in both the number and the quality of available interpreters in Nevada. The state has taken several steps to address this deficit, including recently revising the Nevada Administrative Code to increase the standards for working as an interpreter in the state. However, the state needs to improve resources to support the pool of interpreters working in the state. There are limited opportunities in Nevada for training new interpreters or building skills among currently registered interpreters. To help us determine the path for making these improvements, the Commission needs input from someone who's registered with the Nevada Registry for Interpreters for the Deaf, which is maintained by the Communication Access Services Program in the Aging and Disability Services Division, and therefore is somebody who has a knowledge of the standards for working as an interpreter, knowledge of the systems of training and developing interpreting skills, knowledge of the practice of interpreting, and the ethical and cultural standards of that practice. ASL interpreters are valuable allies and partners to the Nevada Deaf Commission and of the deaf community throughout the state. We wish to invite a voice from their ranks to join us at the table and help us with the vital work that we're doing on behalf of the deaf and hard of hearing individuals in Nevada. And therefore, we at the Commission thank the Committee on Health and Human Services for your consideration of our request to add this seat to our Commission.
We can walk through the sections of the bill very quickly.
We're going to go ahead and just move into questions.
Okay, great,
Since
yes.
we've all had the opportunity to read the bill in front of us. Okay, I'm going to start with Assemblyman Nguyen, Taylor, and Hibbets.
Thank you, Madam Chair. Again, thank you, my colleague, Assemblywoman Brown-May, to really bring amazing energy to this committee. So thank you. Should be TBM day here. So my question, I have two parts follow up, if I may, Chair. I think it's awesome to make the revisions and include this part. My question is that committees usually operate better in this level through an odd number. I wonder why we didn't keep it an odd number versus an even number, just in case of any types of tie that we need to break. And then second part of that question is that now that you're including someone from the profession, I would encourage maybe thinking about having, since we're going to go back to an odd number, perhaps adding another person that could be from a background of another language outside of the American Sign Language, so that there could be perspective in terms of the growing population in our state, of the diverse community that we all represent.
Thank you, Assemblywoman Brown-May. For the record, those are great recommendations. We're certainly happy to consider that as we go forward. The recommendation to add one member of American Sign Language to the commission came directly from the commission members, but I'm happy to take that back and talk it through. Thank you for that.
Great. Thank you very much. Thank you, Chair.
I think the thought of the even number versus odd number was not answered. Do you have a thought on whether that's helpful or?
Thank you, Assemblywoman Brown-May. I don't know whether any vote has ever been that close to really warrant the concern about an even or odd number, but I'm happy to take that back to the commission and see what their recommendation is.
Yeah, thank you, Chair, for pointing it out. Thank you.
Thank you so much. We had a couple folks with that same question. So are there any other questions from the committee before we move into testimony? Seeing none, we'll go ahead and move into testimony. Thank you so much. We will move into support testimony on Assembly Bill 206 here in Carson City and Las Vegas. If there are folks who would like to testify in support, please come up to the desks. Seeing no one getting up in Carson City and no one approaching the desk in Las Vegas, we've had one. Please go ahead.
This is Connie McMullen again, and speaking on behalf of the Commission on Aging Policy Subcommittee and a former Commission on Aging member, I support this. They've worked so hard to bring all these issues forward throughout the years, and they're so necessary. So thank you.
Thank you so much. I have a couple friends in the ASL translation community, and I know they would appreciate this effort as well. Are there other folks? Oh, please, in Las Vegas, remember to state your name for the record. You may begin.
Madam Chair, members of the committee, Ricky Gurrier with Tri-Strategies on behalf of Opportunity Village. I'll keep it short. We support this legislation and look forward to working with the Assemblywoman moving forward.
Thank you so much. Seeing nobody else approaching the desk in Las Vegas or Carson City, we'll move to the phone lines. BPS, is there anyone on the phone lines who would like to testify in support of Assembly Bill 206?
To testify in support of Assembly Bill 206, please press star 9 to take your place in the queue. Again, to testify in support of Assembly Bill 206, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you so much. We'll move into opposition testimony first in Carson City and Las Vegas. Then on the phones, is there anyone in Carson City or Las Vegas in opposition to Assembly Bill 206? Seeing none, BPS, I'd ask you to check the public line for opposition testimony on Assembly Bill 206.
To testify in opposition to Assembly Bill 206, please press star 9 to take your place in the queue. Chair, there are no callers to testify at this time.
Thank you. We'll go ahead into neutral testimony on Assembly Bill 206 here in Carson City and in Las Vegas. Seeing none, BPS, is there anyone on the public call-in line for neutral testimony on Assembly Bill 206?
To testify in neutral for Assembly Bill 206, please press star 9 to take your place in the queue.
Hey everybody, this is Catherine Nielsen, Executive Director for the Nevada Governor's Council on Developmental Disabilities. Madam Chair, I'll make all of my comments very short and brief today. I echo all the comments that were made today. We held town halls with the Commission for Persons who are Deaf and Hard of Hearing last year, and the overall consensus was the increased need for interpreter services in the state of Nevada. By adding an interpreter seat to this commission, you will increase the access to those who are deaf and hard of hearing in the state of Nevada and reduce barriers to accessing information that is vital to their lifetime. So thank you very much for your time today.
Thank you so much. BPS, is there anyone else on the line for neutral testimony?
Chair, there are no other callers to testify at this time.
Thank you so much. I'd invite the sponsor. She's waiving her final remarks, and we'll go ahead and close the hearing on Assembly Bill 206. And I will pass on the chair responsibilities to my vice chair here and move on to Assembly Bill 155.
Thank you, Chair. And when you're ready and all set, let us know and we'll start the hearing. Okay, let's now open the hearing on Assembly Bill 155. Chair Peters, if you would like to proceed. Thank you.
Thank you, Vice Chair and committee members. I'm Assemblywoman Sarah Peters, and I represent District 24 in Reno. Cancer has touched us all, whether a friend or a family member or even ourselves. Diagnosis and treatment can be a long and stressful process with many ups and downs. Today we will talk about what biomarker technology is and how biomarker testing is used at different times in the treatment process. My co-presenters today will discuss the vision for this legislation and the impact to patients treated with a process inclusive of biomarker testing. We have a bit to go through today, so I'll hand the presentation off to my co-presenters.
Mr. Chair and Committee, thank you for the opportunity to present in front of you today. My name is Randy Johnson. I am the Government Relations Director for Nevada for the American Cancer Society Cancer Action Network. To start off, in your packet you have a proposed conceptual amendment on Assembly Bill 155, and so I just want to go over that. In the original bill that was presented, it had a lot of extra language that we did not intend to have in the bill, so this proposed conceptual amendment is an attempt to clarify and really clean up some of that language. So the overall intent is to limit the scope of the bill to health insurance coverage requirements for biomarker testing. So you'll see Section 1, we will remove from the bill the preamble on page 2, lines 1 through 14, and page 3, lines 1 through 28. Sections 2 through 10 and Section 31 relating to the task force on precision medicine and biomarker testing. C, in Section 12, provisions that establish a month of March as Precision Medicine and Biomarker Testing Awareness Month and require that the governor annually issue a proclamation to raise biomarker testing. Section 28 and 29 will require the Department of Health and Human Services to contract with a college or university to another qualified entity and conduct research in the field of public health and study awareness and access to precision medicine and biomarker testing. Number 2, you'll see we want to revise the definition of biomarker and biomarker testing in subsection 3 of Section 12. I believe it's at page 9 of your packet. And you'll see that language below. Number 3, we want to revise sections 15, 17, 19, 20, 22 through 24, and 27 that requires various public and private health insurance to provide certain coverage for biomarker testing as follows. And so you'll see in Section A will require health insurers to cover biomarker testing for appropriate management and ongoing monitor of disease conditions. You'll see the language again added below. For B, we'll revise the language regarding medical and scientific evidence supporting biomarker testing to add additional items related to the United States Food and Drug Administration, or the FDA, and you'll see that language below. And C, revised language that nationally recognized clinical practice guidelines are informed by assessment of risks instead of costs as an alternative for care. And then number 4, make other conforming changes necessary to the bill. And then just want to also clarify for the record that it's not our intent to widen or narrow the population of people who can order a test. If you have any questions on the proposed amendment, be happy to help.
Vice Chair Sarah Peters, for the record, I also want to confirm, I did check in with legal right before we started today. What we are proposing is a new type of lab, right? So anybody who could write a prescription or require a lab from a person would be included under this bill, but those labs are limited to a handful of types of physicians that are, some of which are listed here on sub D of Section 3 of the amendment. But would it also be optometrists, podiatrists, dietitians or dietetics, and I think there was one other one. But I will have legal draft that up and get everyone that information of who would be able to prescribe these labs. Our presentation today had some information on where biomarkers come and go, but we are a little bit crunched for time. I know most of you want to get home to your families and have flights that you'd like to make it on. So we have a physician here in Reno at the table here, who has some history in biomarkers and oncology.
Yes.
And I'd like to offer an opportunity to share some of their experience.
Please go ahead.
Good afternoon. I'm Dr. Lee Schwartzberg. I'm a medical oncologist and chief of hematology and oncology at Renown Health in Reno. I've been a practicing medical oncologist and clinical cancer researcher for over 30 years, and I've seen the field transform from a situation where we gave treatments that were not necessarily based on the individual's type of cancer or their underlying characteristics, and so it was somewhat generic or empirical, if you will. And as a result, only a fraction of individuals actually benefited from any given treatment. And we made advances, very small advances over time. In the last 10 years, as we've understood the biology of cancer better, we now understand that we can find a particular characteristic of each cancer and target that cancer with drugs that can be developed to specifically take care of what's in the cancer that's not in normal cells. And this is true precision personalized medicine, giving the right therapy to the right patient at the right time. In doing so, the advances have been remarkable, and what we found is that more individuals are responding, their cancers are shrinking, they're living longer, and in many cases, even for people who have advanced cancer, it can become a chronic disease. In addition, many of these therapies, although not all, are oral therapies and can be given as little as one single pill a day to get pretty remarkable results. Biomarkers are characteristics that are found in a cell or a tissue or in the blood that we can test and then tell us something about the individual vulnerability, if you will, for a disease. And then we can design drugs that work against that specific vulnerability, sparing normal tissue so that you don't have as many side effects. There are many different biomarkers, and what we're asking for here is the ability to have every individual in the state access to testing for biomarkers which are truly life-saving in the right in the right setting.
I want to clarify, because there's been some confusion on when biomarkers are appropriate. Sarah Peters, for the record. Biomarkers are not preventative. Biomarker testing is not preventative, and it is not diagnostic. It is post-diagnosis used to indicate best treatment. So this is limited to folks who are already being treated for a disease that has a biomarker test available for it. There are approximately in the presentation, there's a slide, I don't remember which slide number exactly, that looks at how many biomarker tests are available on the market, or I believe that's what it is. And there's only like 79 biomarker tests available on the market to date. But the benefit to the populations that have those biomarkers expressed can be hugely impactful on the treatment of their disease. Unless there are other components we want to talk about, we can move into questions. Sure. All right, we'll go ahead and move into questions if that's okay with you, Vice Chair.
Yes, thank you. Assemblywoman Thomas.
Thank you, Vice Chair, and thank you for this presentation. I just, I have a comment, and then I do, want to say that this is amazing, amazing science, and I am impressed, especially when I did my own little brief research and saw that, Alzheimer and dementia, that can also have a biomarker in there. And I am just so impressed with the way science is going to make us better. So thank you so much for this.
Assemblywoman Newby, and then
Thank you, Mr. Vice Chair. I echo my colleagues' sentiments. I once was in a book club and made everyone read The Emperor of All Maladies, which is the history of cancer and cancer treatment. And so we've come a long way since that time. Interestingly, I was never asked to pick a book again for that book club. But I understand that there's going to be an additional cost to add on or to do this biomarker testing. But can you speak to how, on the back end of that, there's the possibility of more tailoring of those treatments to result in fewer treatments tried and fewer, more aggressive steps being taken, perhaps, thus maybe leading to cost savings?
Yes, I think you're exactly right. I'm sorry, Lee Schwartzberg. I think you're exactly right that if you do a biomarker test, the tests themselves are typically not very expensive, actually, relative to other diagnostic tests that are done. But the value that they generate is huge, because if a test is positive, then gives an indication for a particular type of treatment. And in the past, without knowing that, we're treating large groups of individuals to benefit some, but we don't know the characteristics in those large groups if we don't do biomarker testing. With biomarker testing, we might treat a small percentage of each disease. And, you know, it's worth pointing out that cancer, as you said in that probably the best book ever written on cancer, has really changed from a couple of diseases or named for the organ it starts. And in each organ, there are many different subgroups. Lung cancer is probably the best example of this. Lung cancer used to be one or two groups defined by what it looked like under the microscope. And now we see that most lung cancers are small groups of individual genes that are altered. Each of those today, in the last 10 years, we now have, for 2/3 of lung cancers, a specific therapy that targets sometimes 1% of patients, sometimes 10%, sometimes 25%. And they're the first-line treatment. Patients do better if they have their biomarker testing and they know that result, so to get the right treatment first, to get the best result long-term. So in terms of cost, there have been numerous studies looking at the cost of treating with precision medicine, the right therapy for a target that is found by a biomarker. And clearly, if you look at all the downstream costs, you're saving money because you're treating more people more effectively when you know what to treat with.
Assemblyman Gray.
Thank you, Mr. Vice Chair. Yeah, you kind of touched on just what I was going to get. I looked at the fiscal note on this and I just about choked. I mean, when you can target the actual disease you're fighting, you can better know what you're going to fight and how you're going to fight it, what tools to bring to the fight. And in a former life, I was in clinical research, and I wish they had these tools available at the time. You're not taking the shotgun effect anymore, so I think you'll have better patient outcomes. You'll have less money spent, and you'll actually have better results in the long run. So I'm not going to ask. I was going to ask you to justify one thing, but I think you've already covered it, and I think that somebody needs to have their head examined. Whoever did this fiscal note.
If I may respond, Vice Chair, Sarah Peters, for the record, I think there was just a fundamental misunderstanding of the intention of the language of the bill. When the bill's first draft came out, it is large. It's a lot of information that was unnecessary for what we were trying to get at. I will sit down with Medicaid and ask them about the fiscal note and try and bring that down. We will make sure that we address that issue.
And again, this is good science, good treatment, good patient outcomes, and thank you for taking that back with them. You want to bring somebody else to the fight, I'll go with you.
Assemblyman Koenig.
So we've talked today pretty much only about cancer and cancer treatments, but let me ask if what I do would be covered. So we use the term biomarker, and that might be used in a different sense, but I use it to determine whether or not what the chance of someone of getting macular degeneration is. And so when I do my eye exam and look at their macula, if I see certain things that are suspicious. A few years ago, I would do the biomarker test. I would do the cheek swab and we'd send it in, and then they would come back with their genetic makeup and they'd tell me what percentage of chance these people have of getting macular degeneration. Just by looking at it, I can't always tell. I mean, some people that look this way get it, and some people that look this way don't. And so if I say you've got potentially having that, especially if it's in family history and things, and then I have the information that I get back from what we call the biomarker test, and you might say that's the wrong definition for what I'm doing, but then if they are high or risk, then I'm going to bring them back every 3 months, every 6 months, and do further testing, measure the thickness of their macula every 6 months, and if it starts to thin, then we're worried about it. So mine is more preventative and know who to monitor closely until they actually have it, and then at that point I typically refer them to the specialist, but the specialists say don't send them to me unless they actually have it. So would what I'm doing fall under this?
Dr. Lee Schwartzberg. Yes, that is a type of biomarker for sure. And biomarkers have a broad potential range in the sense that they can be used to be predictive or even prognostic. We have which tells you the natural history. It depends on the accuracy of the biomarkers. So we can use them in a pre-diagnosis state, which is what I think you're describing very well. And they have some utility there. Depending on the accuracy of the test, it may be very good to help hone your exam and how often to see the patient, or it may not be particularly good. For the context we're talking here, I think it's more about biomarkers that direct a therapy, though. So there is a whole group of biomarkers for prediction, and we'll be seeing more of these across many different diseases. It's not limited to cancer, as you state, and we can find biomarkers in other diseases as well. But I believe the focus here is really on a biomarker that helps influence what you're going to use to treat a specific disease.
If I may, Vice Chair Sarah Peters, for the record, we are in active negotiations with the insurance company right now on what it is that is intended to be covered. And I think some of that is dependent on the availability and cost in some cases. But you bring up a good question, right, is when is diagnosis? In the case of optical diagnosis, the potential of a patient to have a disease that is treated in a certain way, it falls into an interesting gap, right? And so I will take this question as we move forward in fleshing out the amendment with our stakeholders, and I'll get back to you on whether that will be included or not.
Just a quick follow-up, Vice Chair.
Yes, please.
And so I haven't done that test for a few years because it wasn't getting paid. It was hit and miss. Sometimes it would get paid, sometimes it wouldn't get paid. If you're a person on Medicare on a fixed income, it's not crazy expensive, but it's expensive enough that all of a sudden when you said this is probably covered by insurance and then it's not, here's how much it is, it was unpleasant enough that I actually stopped doing that testing. But in the long run, insurance companies are going to save money on that because now I'm testing everybody that's suspicious, and if I had this test back, I would only be testing the people that were at the highest risk of getting that disease. So.
Thank you. Assemblywoman Gonzalez.
Thank you so much, Vice Chair, and thank you so much for the presentation. My first comment is if I can be added as a co-sponsor. And my second is, I don't really know if it's a question or maybe a comment. I've heard a lot about insurance and saving money. I really wanted to put on the record that when we're talking about these certain types of treatments, the heaviness and the weight that you have, like for a cancer patient, for example, to go through chemotherapy, right? And so I just wanted to put, not only are we saving money, but we're also saving people's time. We're saving them the energy and their bodies physically that could be prevented for a treatment that may not even work, right? Thank you.
Yes, that is accurate.
Okay, I think that covers all the questions. Oh, Assemblywoman Thomas.
Thank you, Vice Chair. And also, I would like to be on this bill. Thank you so much.
Okay, I
We'll
think.
add both of you. Thank you so much.
And I think there were some others in the chat, so if you could follow up with those. Well, thank you for all the questions and testimony. I think we can move now to support, opposition, and neutral testimony. If anybody here, I see somebody in Las Vegas, and anybody in Carson City would like to testify in support. If you are testifying, please remember to clearly state and spell your name. And let's go to Las Vegas.
Good afternoon, Chair Peters and members of the Assembly Health and Human Services Committee. My name is Rupesh Preet, and I'm a medical oncologist here at Comprehensive Cancer Centers of Nevada. As Dr. Schwartzberg outlined earlier, the importance of precision medicine in what we do every day is the utmost importance in how we direct our treatments. On the behalf of Comprehensive Cancer Centers, we're proud to support AB 155, which would not only ensure health plan coverage of biomarker testing, but also to expedite authorization process as it relates to the plan approvals for these specific tests. We're the largest cancer network in the state. We have over 40 physicians, 17 advanced providers, 600 healthcare employees, and 15 cancer centers to try and do these treatments. We participated in these trials that got some of these biomarker testing and drugs available. To date, I think Comprehensive Cancer Centers has been part of 100 new drugs over the last 40 years that have been developed to get these medicines to market. This is what precision medicine really comes down to. Targeted therapy, customized therapy, making the patients live longer, not wasting their time with what we call broad spectrum treatments. As more and more of these treatments are available, there's also been a demand for access. My colleagues and I rely heavily on these mutations and to treat certain types of cancers to accurately construct a treatment plan. Let me give you a couple of examples. I'll start with the ballet teacher. So this lady I've known now for approximately 5 years. I'll call her CF. She was a ballet teacher here from Nevada, ended up with a rare cancer, went to UCLA, went through all the standard treatments, went through the clinical trials, and essentially failed. Came to me and said, "Can you make me comfortable? Can you help me die?" And in Nevada, we don't have a right to die law. So she was actually planning a trip to go to Oregon and Washington. And I ran a biomarker test on her, found a mutation, and I had a drug that was available for another cancer type. Compassionate use medicine was approved. Now she's here 3 years later, surviving with stable disease, healthy, and teaching her ballet students. That's what it's all about. I'll talk about the proud grandmother, example number 2. Diagnosed initially in 1996, cancer stayed away, came back just recently, about 2 years ago. There was so much cancer and she was in such bad shape, she wasn't really a good candidate for a standard chemotherapy. I was able to get biomarking testing done, found an immunotherapy drug that was working, that works for her, and now she tells me every time I meet her, another birthday has gone by. She's seen 15 birthdays over the last year because we've kept her alive due to biomarker testing. Our patients shouldn't have to be forced to pay out-of-pocket costs for what is readily available to the privileged who can go to major institutions for their care. This is standard of care in our field. We have the ability to do these treatments right here in Nevada. We just need access to the testing. It's also very encouraging that this bill provides health plans to expedite prior authorization requests for biomarker testing. When treating cancer patients, as we all know, time is of the essence, and countless delays has ended up causing detrimental harm to some of our patients, and sometimes unable to treat because they've passed away already. Prior authorization procedures as a whole are notorious for causing harmful delays in care when health plans are not held to the standards of transparency and timelessness. An expedited process for prior authorization will ensure that any harm caused by administrative delay can be minimized as much as possible. So from Comprehensive Cancer Centers and all the oncologists I'm sure in the state, we are excited to support this legislation and ask you to do the same. Thank you, Chair Peters, for sponsoring, and I'm happy to answer any questions.
Thank you very much for your testimony. And is there anybody else in Las Vegas who would like to testify? Seeing none, let's move to Carson City.
Hi, I'm Connie McMullen, and speaking on behalf of myself, my husband died 4 years ago of pancreatic cancer. He survived for 2 years. The first 7 months, he had chemotherapy and then went into remission, and then it came back with a vengeance, and it changed with a vengeance into some other brack, way above my level of understanding. But whatever chemotherapy we used after that did not work, and we tried everything to keep him alive. He had stage 4, and we knew he wasn't going to live long. He was terminal, but we just wanted to extend his life because he had such a great life and great reason to live. And when he was ready to die, he was preparing for radiotherapy. Anyway, this is so needed, and it's so exciting, and I would have loved for him to be here to hear this. And I thank the bill sponsor and all of you and hope that you approve this as well. Thank you.
Thank you for your testimony, and we're sorry for your loss, but thank you.
Good afternoon, Vice Chair and members of the committee. For the record, my name is Carrie Harrington. I'm the Executive Director with Nevada Cancer Coalition. We are the state's nonprofit organization bringing together both public and private healthcare providers to work together on reducing the burden of cancer in our state. Our vision is simple: healthy communities across Nevada with equitable access to quality cancer care and support for every human being. However, as you know, cancer is not so simple. It's the second leading cause of death in our state, and in 2023 alone, over 17,000 of our friends, our family members, neighbors, and colleagues will hear those words, that you have cancer. As you've heard, biomarker testing is an essential step in developing a personalized cancer treatment plan, providing access to the latest innovations in cancer care. However, not everyone in our state is able to benefit from the latest advances in biomarker testing and precision medicine. This is inequitable access to care in our state. Improving coverage for and access to biomarker testing, as you've heard, across insurance types is key to reducing health disparities in precision medicine and really providing cutting-edge care to everybody. As such, we support AB 155, and we thank you for your work in helping to reduce the burden of cancer in Nevada. Thank you.
Thank you. Our next supporter.
Barry Cole, Barry Cole. Dr. Schwartzberg? Maybe he could remind me what chomp, mop, and bop meant, but when I was a medical student becoming an intern, I gave people complex regimens of multiple drugs that weren't even as precise as a shotgun. It was more like a hand grenade. You just hoped it hit something. Outcomes were terrible. Side effect burdens were god-awful. And then I had cancer. And I was lucky. I could actually work myself up. I could actually find a surgeon who could remove my cancer in mass so that it was completely removed. I obviously didn't pick my family very well because both my parents had cancer, 2 of my 4 grandparents had cancer. This is the high frontier. This is what we have hoped we would finally get to, an era of medicine where everybody is their own N of 1. The treatment is unique to you. It's the difference between, like, thinking about Hippocrates 2,500 years ago and Leonard McCoy on the Starship Enterprise, Dr. Bones, with a tricorder diagnosing you precisely and giving you exactly the medicine you need and not the one that fits anybody else. I think this is going to encroach more and more into medicine. We already are looking at this in psychiatry, as weird as that may sound, because we understand many mental illnesses overlap and look very similar, but their treatments are actually very different. And what we're trying to figure out is what medicine treats what condition. So see biomarker testing as evolving past, obviously, cancer into more and more areas of medicine as we begin to understand what markers control what treatments and their outcome. Thanks so much.
Thank you. Let's move to Mr. Clark.
Mr. Vice Chair, members of the committee, my name is Tom Clark. I'm here on behalf of the Nevada Society of Dermatologists and Dermatological Surgeons. Took me a long time to figure that whole thing out. And I've also learned not to follow Dr. Cole all that often because he's just great. We do very much support this particular piece of legislation. At this late hour, I will just leave it at that. We support the testimony that's been given to you previously, and ditto, Vice Chair. Thank you for your time.
Thank you. And finally,
I'm Tom McCoy, Executive Director of Nevada Chronic Care Collaborative. Approximately 6 out of 10 adult Nevadans have some chronic condition. Biomarker testing, pharmaceutical research and development has brought us precision medicine, which has brought us improved outcomes and quality of life. So passage of AB 155 will help to expand access to more Nevadans to appreciate this very innovative development. Thank you.
thank you, Mr. McCoy. Anybody else here in Carson City? Okay, broadcasting, do we have supporters on the line?
To testify in support of Assembly Bill 155, please press star to take your place in the queue. Caller, please press star 6 to unmute your phone.
Thank you. Mr. Vice Chair, members of the committee, my name is Joanna Struther. I serve as the Senior Director of Advocacy for the American Lung Association in Nevada. The American Lung Association supports AB 155 to increase coverage of biomarker testing. This legislation will improve access to critical cancer care for patients in Nevada, including those with lung cancer. Comprehensive biomarker testing allows doctors to identify abnormalities in the cell's DNA, which in turn helps healthcare providers determine the best course of treatment for cancer patients. This is particularly important when treating lung cancer, as there are currently FDA-approved lung cancer treatments for tumor abnormalities in 7 distinct genes. Studies show that lung cancer patients that have access to biomarker testing are thus able to receive targeted therapy treatments and have better overall chances of survival. Biomarker testing is a critical part of both cancer care and treatment of other chronic conditions and has been incorporated into many clinical guidelines so that doctors may make the best decisions for their patients' health. Increasing coverage of biomarker testing will also improve health equity in Nevada and make cancer and chronic disease care more affordable and more accessible for patients. With that, the American Lung Association supports AB 155. Thank you.
Thank you. Next caller, please.
Chair, there are no other callers to testify at this time.
Thank you. We'll move to opposition testimony. Is there anybody here in Carson City who would like to testify in opposition?
Good afternoon, Chair Peters and Vice Chair Orrin Lichter, and members of the committee. For the record, my name is Dana Sullivan Kilroy. I'm using all my Irish names today. Dana, D-A-N-A, Sullivan, S-U-L-L-I-V-A-N, Kilroy, K-I-L-R-O-Y. I'm representing Foley Public Affairs and the Nevada Association of Health Plans, and appreciate the opportunity to provide comments on AB 155, which establishes provisions relating to biomarker testing. The Nevada Association of Health Plans is a statewide trade association representing 10 member companies who provide commercial health insurance and government programs to Nevadans. Our mission is to ensure the growth and development of a high-quality and affordable healthcare delivery system throughout the state. We have submitted a letter for your consideration, but wanted to bring a few issues of concern to your attention today. First, biomarker testing legislation with loose definitions of medical and scientific evidence will lead to increased costs, unnecessary testing, and worse health outcomes due to false positives and overdiagnosing. Two, Health plans already cover a substantial number of evidence-based biomarker tests consistent with medically necessary clinical guidelines. There's already rapidly increasing availability of new tests as carriers review published evidence and professional guidelines to create evidence-based criteria that are meant to drive appropriate, safe, and effective care. The use of biomarker testing must be based on peer-reviewed medical literature and be proven to materially improve net health outcomes. We've gone into more specifics in the letter we submitted and urge you all to read it. We appreciate the opportunity to provide comment and would also like to analyze the amendments as we have not yet had chance to do so. Finally, we look forward to collaborating with Assemblywoman Peters and the committee to resolve these issues. Thank you.
Thank you, Ms. Kilroy. Anybody else in opposition here? Okay, in Las Vegas, anybody who would like to testify in opposition? Okay, broadcasting, do we have anybody on the phone line?
To testify in opposition to Assembly Bill 155, please press star 9 to take your place in the queue.
Hi, my name is Stacey. Hi, my name is Stacey Sasso, representing the Health Services Coalition. The coalition covers 25 employer and union-sponsored health plans, including Culinary, Metro Police, Clark County, and various other groups, with a total of about 280,000 covered lives. We're in opposition of AB 155. We're still reviewing the newest amendment that we just saw today. However, this bill does go further than we were told was the intent, and we'd like to continue to work with the sponsor on finding something that can work. Thank you.
Thank you. Next caller, please.
Vice Chair, there are no other callers to testify at this time.
Okay, let's move to neutral testimony. Anybody here who would like to testify in neutral?
Good afternoon. My name is Sarah Watkins, and I represent the Nevada State Medical Association. For the most part, we're in support of this bill, and we appreciate working with the bill sponsor. But today we are neutral as we wait to see the amendment come back and make sure the scope of who can order these tests isn't expanded. Thank you for your time, and thank you to Assemblywoman Peters for working with us.
Thank you, Ms. Watkins. Anybody else here? Las Vegas, is anybody in neutral in Las Vegas? Okay, let's go to the phones. Broadcasting, do we have anybody on the line in neutral?
To testify in neutral for Assembly Bill 155, please press star 9 to take your place in the queue.
Hello, my name is Wes Falconer. I'm the Chief Operating Officer of Cancer Care Specialists in Reno. We're the second largest oncology group in the state of Nevada and the largest privately owned oncology group in the state of Nevada. We have clinics in Reno and in Carson City. And while we're, for the most part, supportive of this bill, we want to remain neutral until further details are worked out regarding the bill. Some of those details that need to be ironed out are what type of physician can order the test, and then we believe that the test should be used for confirmed diagnosis and not for preventative measures. We also would like the State Assembly to consider the cost of care with the use of biomarker testing.
Thank you. Next caller.
Vice Chair, there are no other callers to testify at this time.
Okay, thank you. We can close the hearing on Assembly Bill 155. Chair Peters, would you like to finish remarks?
I just wanted to reiterate that we are continuing to work with stakeholders on this bill and to formalize the final amendment that would be brought before you as in a work session document if we can get it that far. I appreciate your support. Thank you.
Thank you for bringing this bill. And now I will close this hearing on Assembly Bill 155 and welcome you back to your chair's role.
All right, thank you so much. So we are closing out hearings for the day and moving into our last agenda item, public comment. You can provide public comment in a variety of ways. We will be taking in-person and phone public comment at the moment. We are keeping public to 2 minutes for fairness. You may also submit public comment in writing if you'd like to go further. Staff will be timing each speaker during public comment. Well, is there anyone in Carson City who would like to provide public comment today? Seeing none, Las Vegas, is there anyone who would like to provide public comment today? Seeing none, BPS, is there anyone on the public comment line who would like to provide comment today?
If you would like to provide public comment, please press *9 to take your place in the queue. Chair, there are no callers choosing to provide public comment at this time.
Thank you so much. We'll go ahead and close out public comment. Are there any additional comments from the members before we adjourn? Thank you all for hanging in there. We got out of here a little bit later than I'd like, and I know we all like to get home, so we're going to adjourn this meeting, and I'll see you all on Monday.